So, good morning, everybody. I would like to thank KSOS for giving me this opportunity. And we have this interesting case of double vision and pain. So, I had this middle aged farmer. Um, he was working in the fields, and all of a sudden, he suddenly developed a severe neck pain 2 weeks before he presented to me, following which he developed a blurred vision in both eyes and diplopia. On examination, his vision was 6/6 in both eyes. His anterior segment was completely normal. Pupil was round, regular, and reacting. There was no RAPD. On cover test, there was a esotropia for both distance and near. Extraocular movements were full and not painful. There was no limitation in any of the gaze directions. Color visions was normal. Then I did a PBC, Prism bar cover test, and he was found to have a esotropy of 12 to 14 base out for distance, and for near it was 25 base out. This was the fundus picture. So this is a red-free picture. You can see that there is a large amount of disc edema. There was a papilledema, Frasen's grade 4 papilledema, and you can see that there are hemorrhages. If you can see in these areas, those bright areas are all hemorrhages. And this was the OCT, EDI OCT through the disc. So you can see that there was a gross edema. This was the fundus picture, and there was an enlarged blind spot in both eyes. I got an OCT done, and you can see that in the OCT, the RNFL layers are quite thickened in both eyes. This was a GCC. GCC was quite normal in this patient. So the first thing that we think of when a middle-aged person comes and there is a papilledema, the first thing is check the BP. That is what we are taught always. So check the BP, and BP was quite normal. And again, I repeatedly inquired about the medical history. No significant medical history, no prior episodes of any thrombotic events or anything. Then I also got simultaneously a blood test done, and a neuroimaging was my next thing because I was thinking of an intracranial space occupying lesion. I got an MRI brain orbit plane and contrast with an MRV. So both brain plane and brain and orbit plane and contrast was normal, completely normal. But MRV, if you can see onto the left side, you can see that there is a partial patency of the transverse and sigmoid sinus. You can see on the left side of the picture that it is partially patent. This was the another view. You can see a lot of collaterals have developed. Okay, and there was a because of this old thrombus which was partially recanalized of the left sigmoid, transverse and straight sinus and superior sagittal sinus. So the impression that we got from the radiologist was it is an old thrombus with partial recanalization. And of the left sigmoid, transverse and straight sinus, and right side was completely normal. So again, I was going in terms of, okay, so probably this is an idiopathic intracranial hypertension, that is how it is. But before labeling it as a idiopathic intracranial hypertension, you need to rule out any other conditions that we are missing out, because idiopathic is when you don't detect any cause. So further, I went in for the complete blood checkup, and ESR was normal, no other abnormalities in the blood count. APTT was normal. I did a connective tissue workup, that was also normal, but homocysteine level was found to be raised. So then I got a neurology, also simultaneously I sent for a neurology reference, and he started them on anticoagulation therapy. And after having started the anticoagulation therapy, after 2 months of this, the papilledema resolved completely. And this was the picture. You can see the RNFL pre and post. It has completely resolved. GCC is quite normal even now. So what I would like to tell is that before labeling it as a case of idiopathic intracranial hypertension, you need to rule out other causes. So this was a case of a chronic CSVT with an acute exacerbation which presented to us like this. And elevated homocysteine, if detected early, it can prevent other thrombotic events in the future. So that's what I would like to say. Thank you.
Thank you, Dr. Soumya, for that wonderful eye-opening case. So, Madam, any opinions, comments on?
Homosnemia, or that is one of the things which we rule out. Even though it is not very common, we do come across. hyperosmotic conditions like homocysteine.
One thing that went against IHS, usually you see it in females, you see it in an obese female, but this was a male, again, very farmer who is thin built, working and things. So whenever you have a atypical IAH cases, you have to think in this way. Otherwise, you tend to miss out. Any other?
Very interesting case.
So fact to be stressed is any case of papilledema, not only you have to do an MRI, you have to do an MR venogram. Because three things you want to rule out: an SOL, a cortical venous sinus thrombosis, and of course subtle signs of IH which you may pick up. And in any male patient, before labeling as IH, definitely we have to rule out CVST. And what would be the, like, of course you had, we have a lot of patients, sometimes there is no cause also for the CVST. Sometimes it's idiopathic, we don't know, dehydration coupled with alcohol, all these are supposed to be, and they can even lose vision. They can come with sudden fulminant, vision loss, and they can actually lose vision. So we have to, 2-3 patients like that who are diagnosed as CVST, borderline, hypercoagulable states. You have to even do an extensive hematological workup, including protein C, protein S deficiency. I've had one patient with protein S deficiency who had this bilateral papilledema, who presented with double vision and all that. So the take-home message, I think, this would be to do MR venogram and to distinguish whether it's a stenosis or a thrombosis. That the radiologist will be able to tell you whether it's a transverse sinus, because it's a dynamic scan which tells you whether it's a stenosis, because that can be seen in IH, or it's a thrombosis. So if it's a thrombosis, you have to treat it like a cortical sinus thrombosis, unless proven otherwise.
Yeah. So
What is your take, ma'am, in such scenarios? Is it's totally a neurologist perspective, but LP, how indicated?
No, we will send, when we get it as CVST, we will definitely send to the neurologist to get an opinion, and it's up to them whether they do a lumbar puncture. If they're sure about the diagnosis, they will initiate them not just on anticoagulants, also Diamox, and they will follow up the patient. But we had 2 patients who presented with a young patient who worked in the IT field, who presented with sudden loss of vision, diagnosed as CVST. Then we had to do optic nerve sheath fenestration for him. He had no other complaint. He suddenly presented with, loss of vision. So I don't know what is the cause. The final thing was he had high hemoglobin. And that was probably, thought to be the reason, coupled with his irregular eating habits, dehydration, and alcohol use was the potent risk factor.
Does this post-COVID hypercoagulable state apply to this also, or?
yes, I did read up after this
Possible.
case.
Post-COVID, all sorts of things have flared up. Autoimmune disorders, hypercoagulable things.
States.
COVID-19 has caused CVST. I mean,
CVS,
there are many cases which has been reported
Causes
like that,
venous
yeah.
occlusion also. We had one or two cases of venous occlusion and this thing.
Yes.
And the profile also of IAH is changing, I feel. Have a few patients who are, like me, and they have IIH. So recently also I had one lady who is very thin built, typical IIH. So I think
I
that
have
is also
had
changing.
young children also presenting, because nowadays obesity in children are also
Yes, yes.
increasing. So we need to have everything in the back of our mind. It may not be a typical IH. It may be an atypical IH, where you have to do all the workup.
Maybe in this case the thrombosis was very evident, and that's why they would not have gone for a lumbar puncture.
Yeah, yeah.
Otherwise, the diagnostic test for an IAH is anyway
Yes.
a lumbar
Yes,
puncture and
yes.
opening pressure.
Yes.
After that only they would have started the anticoagulants. So maybe he was very confident with the diagnosis.
Also had one patient with dural AV fistula presenting it to us as bilateral papilledema. So that was missed actually. Patient came from elsewhere for a second opinion, and patient was had bilateral florid papilledema. His vision was, fields were constricting. When he came to me, he had 6/6 vision, but he was his fields were small tubular. So he didn't have any scans. The diagnosis was written as IAH. So we sent him back to the neurologist saying that he's not getting better with Diamox, repeat the lumbar puncture, repeat imaging. Then he came back with the diagnosis of dural AV fistula. They redid the MRI, and they found it was dural, and he had to undergo a endovascular stenting for the dural AV fistula. That's also a rare possibility. So all these things, sometimes you have to revisit your diagnosis. He was also a male patient. IH, it was diagnosed as IH.
One more thing I felt nowadays the difficulty is like if we are advising for an imaging, I think we need to specify this and this, or maybe contact the radiologist because they are taking MRI from all the places and the reports may not be so um, trustworthy, or I don't know. There has been a lot of discrepancies where I had to directly call and talk to them, and a lot of differences are happening nowadays.
Always send to a center where there's an in-house radiologist, because nowadays people sit somewhere else and read the scans. So unless they have and they are really interested, they may not be, very keen
Very
on
keen
giving
on
you.
a diagnosis.
They usually play it safe. If it's from an eye hospital, they usually have a set of diagnoses. So unless you have a radiologist to whom you can directly talk to, and I usually don't send to any center. I insist that please go here. It's not because I have any financial interest. It's because I can talk to the radiologist and he can talk to me, and we can have some relevant, discussion about your case.
I think the radiologist reporting is very much, it does play a major role, is what I feel, in neurophthal at least.
Recently, we had a case where the patient had an unexplained, there was a pituitary microadenoma, but the right eye was showing RAPD. The patient specifically says that the vision loss is very minimal, like 6-9 parts or something like that. But there is an RAPD, and the MRI, apart from this microadenoma, is normal. Then I had written that it all corresponds to a compressive kind of optic neuropathy. Something could be there. But then she was lost to follow up, and then she comes back after 1 year. It is an meningioma right in the optic canal, like optic nerve meningioma. It was probably very small and was missed. So, yeah, radiologists are very important.
Anyway, thank you. Thank you, one and all.